So we'll have two interesting cases. Our presenter, Dr. Mariam Al-Agami, was oncology resident at Mansoura Oncology Center. Yeah, you can go ahead.
Is the screen clear?
Yes.
Yes.
Hello everybody, I am Mariam Al-Agami, medical oncology resident. We will today inshallah discuss rare adverse events of some chemotherapeutic agents in treatment journey of hematologic cancers. We have two case presentations. Case one is a primary breast lymphoma with the secondary CNS lymphoma. Our contents for our first case: initial diagnosis and demographics of the patient, imaging and clinical presentation, pathology and IPT, initial staging CT and bone marrow studies, first line treatment patient had and response assessment, second line treatment and consolidation therapy, then the CNS presentation and treatment plan, the followed complication and our management, and the last, the panelist discussion. Regarding the initial presentation, we have a 28-year-old female patient with echo performance 0 with free medical history and family history. She presented on September 2020 with right huge breast mass, about 5 by 7 centimeter. An excisional biopsy of this mass revealed undifferentiated round cell tumor consistent with non-Hodgkin lymphoma for IPT. Pathology and immunophenotyping, the morphology was undifferentiated round cell tumor tissue with diffuse pleomorphic infiltrate, mature and transformed lymphocytes with inflammatory cells, mainly plasma cells, and histiocytes separated by fibrous tissue bands. The diagnosis was a picture of a non-Hodgkin lymphoma diffuse large B cell type with immunohistochemistry. CD20 was diffuse positive membranous staining of the neoplastic cells. Ki67 was positive in more than 80%, and cytokeratin and CD3 were negative staining. The staging radiology, we have a post-contrast band CT on 2020, which revealed few bilateral small upper deep cervical lymph nodes, 13 by 7 millimeter, with enlarged right axillary lymph node, 20 by 24 millimeter, with suspicious criteria and no other abnormality detected. The bone marrow studies, bone marrow biopsy was a small biopsy with hypocellularity, about 30%, with no lymphomatous deposits in. So we have a right breast mass, excised about 5 centimeters, ipsilateral right axillary lymph node with upper deep cervical lymph nodes. So we have stage 2E non-Hodgkin lymphoma diffuse large B cell type. The first line treatment our patient had, she received 6 CHOP chemotherapy cycles without rituximab, last on March 2020. Then re-evaluation PET-CT showed enlarged right axillary lymph node, 16 by 7 millimeter, with SUV 1.8 likely residual, and peripherally enhancing avid right iliac cystic region, SUV 5.1 for ultrasound. Then she received rituximab 6 cycles, and re-evaluation PET-CT on January 2020 was NCR, no nodal metabolic, and it was anatomic resolution of the previously reported right axillary lymph node and no other metabolically active nodal infiltration. And regarding the previous cystic lesion and the right cystic lesion, it was ovarian functional cysts, non-metabolically active, the largest 17 by 15 millimeter. This is the first CR our patient achieved, and she started follow-up, only a follow-up period of about 6 months. And on July 2020, after 6 months, a superficial ultrasound on the axillary region revealed enlarged right axillary lymph node with lost hyaline, globular shape, and cystic degeneration, 3 by 2 centimeter, with suspicious criteria. And another subcentimetric lymph node on the same side, and on the left side, there were no axillary lymph node. An excisional lymph node biopsy was taken, and it revealed involvement by non-Hodgkin lymphoma diffuse large B cell type with again CD20 diffuse positive. Restaging PET-CT with contrast done and no other pathologic lymph nodes. We decided to start second line chemotherapy with GMOX vinorelbine. 3 cycles were received with the prophylactic intrathecal, and re-evaluation PET-CT on January 2023 was in CR. Our patient continued till the 6th cycle of this protocol, and on May 2023, PET-CT stayed in CR. So we went for an autologous bone marrow transplantation as consolidation therapy with day 0 stem cell infusion on 7th November 2023. After bone marrow transplantation, our patient stayed in CR till April 2025, about 1 year and 6 months. During the follow-up period with the bone marrow transplantation unit, she complained of blurring of vision and dull aching pain in the right eye. First ophthalmology consultation said, and they recommended retinal injection. And after 1 month on May 2025, she reported history of convulsions at home about 2 times. PET-CT was done on July 2025, and it described a well-defined hypodense non-enhancing area in the right frontoparietal lobe of the brain with associated mass effect and mild compression of the ipsilateral ventricle. But PET-CT was recommending it was subacute infarction for MRI. An MRI and MRS describe this lesion as a space-occupying lesion, superficial cortical indication, 34 by 20 by 30 millimeter, with associated moderate perifocal edema and effacement of the related cortical sulci and mild midline shift to the left side, but suggestive of lymphoma. Our panel has decided the patient to receive high-dose methotrexate cytarabine chemotherapy, and she received the first cycle on 8th July 2025. After only 1 week, she presented to the emergency room with febrile neutropenia, bolus eruption, mainly on the right arm, left arm, and the back, with associated diarrhea, oral mucositis. Then this bolus skin eruption developed to extensive bolus skin eruption, mainly on the arms and the back. Dermatology consultation was a picture suggestive of query drug-induced skin toxicity, query toxic epidermal necrolysis, based on the body surface area. Regarding methotrexate therapy, we started calcium leucovorin at a dose of 50 milligram per 6 hours for 2 days, with no improvement of the skin lesion, and also progression of the skin lesion with a skin rash and redness in the sclera. A serum methotrexate level was done, and it was about 0.04, and this was a toxic level. Calcium leucovorin dose increased to 100 milligram every 6 hours, and oral steroids were also added. As shown in this picture, the bolus skin eruption become ulcerative, so dermatology consultation again, and they recommended starting cyclosporin at a dose of 100 milligram every 12 hours with dexamethasone every 24 hours. The scleral injection has progressed to subcutaneous hemorrhage in the sclera, and topical steroids were added. Our patient have marked improvement on cyclosporin at this dose, so we continued cyclosporin till about 14 days. Then we started tapering of cyclosporin. We have a CT scan after one cycle, CT scan on the brain with the regressive course as regard the size of the isodense space occupying lesion previously reported in the right parietal region, now 13 by 90 millimeter with mild edema and minimal mass effect. So would you resume methotrexate at this point, or what would you recommend as an alternative?
Next slide, please, Mariam. So when I saw this case in the department, the first thing I thought is, can methotrexate cause such a toxicity? And the answer is absolutely. It can cause variety of toxicity, from the common toxicity we see like alopecia and photosensitivity to the severe ones like this case causing toxic epidermal necrolysis like lesion. Sometimes can cause pseudo-lymphoma or even rheumatoid-like nodules. Next, Mariam. Mariam.
Okay.
Next. It's frozen. I can't.
If I may ask, Mariam, if you can go to the next slide. If I may ask, what was the dose of methotrexate giving, and what was the dose of cytarabine?
Again, please.
The dose of methotrexate.
The dose of methotrexate and cytarabine given.
It was 3 gram per meter square. Regarding methotrexate dose, it was 3 gram per meter square, as our patient is underweight.
And the cytarabine?
Mariam, can you recall the dose of cytarabine?
No.
Okay.
Okay.
Are you able to advance the slides to the next?
Yes, yes. So this patient is like at least grade 3 to 4 toxicity. Next, Mariam.
Yeah, and I'm sorry, Manar, one question for you. So we were talking about the methotrexate level being 0.04. Like at what time point was this? Yeah, like typically we monitor the we do the leucovorin and urine alkalinization and monitor the the methotrexate dose. And typically if it's, I mean, it's different from place to place. If it's less than 0.05 or 0.1, it just depends on the place, then these patients get discharged. So I don't know what the protocol is in Egypt, and at what time point was this 0.04? Was this like a couple of days later or weeks later?
One
I
week,
think it
1
was
week later.
1 week, so yes, it's considered elevated.
Okay, and was this the first check or was it checked before that?
It was the first check.
Okay, and did the patient get like leucovorin initially with the methotrexate, or like how was it done?
Yes, per protocol, it's received 24-hour after administration of methotrexate.
I see. And these patients get discharged, like how do when do they get discharged after the high dose
She
methotrexate?
spent like 3 weeks inpatient because of this grave toxicities.
Oh, I see. And the skin necrosis started like when after the chemo?
Can you recall, Mariam, what day exactly?
The skin necrosis started 1 week after chemotherapy.
1 week after chemotherapy. I see. And the kidneys were okay?
Yeah, kidney
And those
function was normal.
okay. Sounds good. Thank you.
Having said that,
Okay.
the kidney function was being judged by the serum creatinine in this patient, I assume. Yes?
Yeah.
Yes.
And this was a how underweight patient?
She's about 50 kg or 52.
Okay, so she's somewhat underweight. Was there any other estimation of her renal function or just the serum creatinine?
We have only the serum creatinine.
Thank you.
Yeah, you mean that when the patient doesn't have enough muscle bulk, the serum creatinine may not represent the renal function?
That is what I'm implying, yes. She is 28. It would be surprising if she had advanced renal disease, but she'd had several lines of therapy. She may have had some toxicity from the early lines of therapy. And certainly, we see this. There is a test we do in the West called cystatin C, which can be done instead of serum creatinine as a spot check of what the renal function is. And often, if we have concerns, we'll do a 24-hour urine to really measure the true clearance.
Yeah, at our institution, we rarely use it. I think, the 24-hour urine creatinine clearance is what we do.
And there is an equation too, using the body weight and age and serum creatinine level and Medscape.
What was her creatinine? Do you know what the number was?
It was normal, it was, around 1.
Right, but was it greater than 1 in this 28-year-old?
No, it's normal. It was normal.
Okay.
Mariam, can you next, please? Okay. So the diagnosis of methotrexate toxicity is a kind to be it has to be like clinical diagnosis because there is no specific lab test that could point at the culprit medication. Like even if she took a skin biopsy, the result will be non-specific. So you have like to look at the temporal relationship to methotrexate and the clinical picture and the presence of risk factors like renal failure, wrong dose maybe, or maybe some drug interaction. And when we stop methotrexate and give supportive treatment and find there is improvement, this will support the diagnosis of methotrexate toxicity. Next, Mariam, please.
So are you sure that this is methotrexate toxicity?
Well, when she stopped the methotrexate and received the immunosuppressive and leucovorin, she improved. But you can't tell you like for 100% sure that it is methotrexate.
Did she have any mucositis?
Yeah.
Yes.
Oral mucositis as well from that?
Yes.
Okay. And you tested the methotrexate level a week later when the symptoms started.
Yes.
Is that your standard, or do you check it daily after the end of the infusion?
If it is available in our lab, we can check it like at 48 hour and at 72 hour. But sometimes it's like not always available, and then we ask for it when it's clinically indicated.
And the leucovorin is only giving for 24 hours?
No, it's given starting after 24 hours of methotrexate and then given every 6 hours as the protocol of
For how
high-dose
long?
methotrexate. It's usually for 12 doses, unless there is toxicity. If there is toxicity, we can give it for longer periods.
So this patient was done getting the leucovorin per protocol by the time they started they're having the side effects a week late, right?
Yes, yes. And then we resumed it back.
Got it. So it wasn't just skin, it was skin and mucocutaneous. The patient had the mucositis as well as maybe diarrhea, maybe nausea, vomiting.
Yeah, yeah. It was multiple toxicity, but the most strange and difficult one was the skin, these bullous lesions.
But
So the
it
problem is,
was not just the high dose methotrexate, right? It was also high dose Aracy.
yes, it had the RC too.
I see.
But I think that this toxicity is common in methotrexate than in cytarabine, right?
Which one? The mucositis or the skin?
The cutaneous.
The cutaneous is, yeah, methotrexate. I have never seen it, so I'm it's very interesting. But definitely the Aracy can cause also mucositis.
Yeah, mucositis. Anyone can cause mucositis.
Right, right.
And the Stephen Johnson as well can be caused by RC.
Yeah.
What about the liver functions?
Mariam, I think the liver function were normal, right?
Yeah, lab were normal apart from neutropenia.
Yes, yes. It was just neutropenia, mucositis, and cutaneous toxicity.
Dr. William, do you have any questions or clarifications you would like to chime in?
Sure. I just reading through the slides, there was a mention that the patient presented to the emergency room. Does that mean that she was discharged at some point and then readmitted again?
She was discharged after receiving a cycle. Then after 2 days of discharge, she presented to us with febrile neutropenia, cutaneous eruption, diarrhea, oral mucositis.
Got you. I think what you're likely dealing with is delayed methotrexate clearance for one reason or the other, because if the level is still detectable after 7 days, it means it had been fairly toxic in the early period. So that's probably why you have all of those things. The skin toxicity I haven't seen. It might sort of require a little bit more inquiry. Apart from the methotrexate, I have two other thoughts about the case. Primary breast lymphoma, especially in patients in our region and the Mediterranean, usually starts as a marginal zone extranodal. So I was wondering if you might be dealing with transformed disease that might be impossible to figure out if all what you're seeing is a large component. So perhaps a more secondary look at the pathology might help you if there are two components that's suggesting a transformed disease. That's one thought. And typically the extranodal marginal zone lymphoma in our region is also usually related strongly to hepatitis C. So I was wondering if this is something that was checked on this patient, might be worthwhile checking as well. And lastly, I would say regarding your main question, should I re-challenge with methotrexate again? I think the more important question really is what's your end plan? So this is a patient who is primary refractory. She relapsed within 6 months of induction. Those patients typically are not cured by chemotherapy approaches. And then once you did the autologous transplant, she relapsed again. So this patient have declared herself to be chemotherapy refractory. So chemotherapy is not gonna cure her. It's mostly would be considered palliative at this point. So that would be one important point about if you should continue chemotherapy in general or not, whether it's methotrexate or something else. If you have access to something like glofitamab, I know bispecifics might not be available in Egypt. The last I checked was another colleague. But glofitamab, if you can obtain it, would be a very good choice because you need an exit plan. You cannot continue methotrexate forever. Methotrexate is not going to cure that lady, whether she's able to tolerate it or not. The only two things that can possibly cause durable remission at this point are CAR-T, which I know is not available,
Yeah.
or a bispecific. Otherwise, the treatment goal is palliative, and if it is palliative, it doesn't make much sense to put her through another set of toxicity. If your goal is palliation, then you probably could do something like high dose Rituxan with lenalidomide or pomalidomide. You can add zanubrutinib to that. There is data for BTK inhibitors and IMiDs and CD20 combination. I would pick zanubrutinib in particular because it crosses the blood-brain barrier better than the others, or classic ibrutinib as well. It would be a good choice, or whole brain radiation. But I don't think there is any point in continuing chemotherapy if you don't have an exit plan. So.
What about allogenic? Can we do in this patient induce remission and then followed by allogenic bone marrow transplant?
I would be hesitant about an allo transplant in a CNS, in a primary CNS disease. I don't think the data are that strong. If it is your only option, you would consider it. But I would be hesitant to kind of, if that's your only option, if patient still had a good performance status, I'll try to control the disease as much as I can before pursuing allogenic transplant. You also might need to be creative with a conditioning regimen. I like use a conditioning regimen that includes Cyotepa, so you can get a little bit of some CNS penetration.
And any rule for the radiotherapy?
What is it, sir? I'm sorry.
Any rule for the radiotherapy?
Oh, right. Absolutely. Yeah. I would do radiotherapy only if you're out of any other option. You would do radiotherapy as palliation. And you can buy a good amount of time with that. But the downside is she's a younger person, so you probably will be experiencing a pretty significant cognitive side effects. She might not live long enough for her to suffer from those. I certainly wouldn't use very high doses. I wouldn't use the same doses that you would use for something like small cell lung cancer or anything like that. I'll use pretty reduced doses.
So several
Okay.
quick questions. The first is the original biopsy. What subtype of large cell, and was any attempt made to look to see whether this was a double hit lymphoma?
It was diffuse large B cell and no BCL2 and BCL6, and they were not done.
I see. So we
But
still
the
don't know
KI
whether
was 80%.
right.
It was aggressive.
Right. So, double hit lymphomas are sort of a category above what we think about with regular large cells, either germinal center or activated B. But even the activated Bs are more complex typically than the germinal centers. And There is some evidence that POLA-based regimens may be superior there. It's a little controversial, certainly in this country, but did she have B symptoms and a very high LDH when she presented?
Mariam, do you have the LDH?
LDH was about 600. She has no B symptoms.
Uh-huh. And do you know if her lymphoma expressed CD30?
CD30 was not done as the CD20 was diffuse positive. CD3 only was done and it was negative.
I see. And you don't even know CD19 then, I guess. Is that true?
No, CD19 was not done.
I see. Okay. Well, some of the therapeutic things that have been discussed will depend on CD19, and I know that some of them are not available in your area, but the question of double hit is a critical one in a patient like this, because oftentimes that really does determine what the initial therapy should be and what secondary therapy should be. This seems to be a very aggressive lymphoma for this young 28-year-old female. It isn't behaving like a standard large cell lymphoma, so I'd be very worried about a double hit biology here. What did she get as far as conditioning for her autologous transplant? Was that a beam auto?
Yeah, beam.
Gotcha. Okay.
So,
Is it
Dr. Webb,
beam
do you
or
recommend any form of CNS prophylaxis in such a case from the start?
Yes. Yes. This patient, this is an excellent point, but this is a patient that we typically would use CNS prophylaxis. I know that CNS prophylaxis is controversial with data for and against, but breast lymphoma, at least in our center, we do prophylax them from the get-go for CNS. And I think from the presentation, the patient did not receive the CNS prophylaxis on first line.
Yeah.
No, she didn't.
In the first line treatment, she didn't receive, but in second line, the protocol GMOX-navalbine, there was intrathecal chemotherapy injection.
Yeah, but she already had CNS disease at that time, right? Is that correct?
Yeah.
Yeah. So let me just ask you a question. So do we typically do CD10 at just to try to see if this is by Hans criteria germinal center or non-germinal center at diagnosis, or typically CD10 is not done?
Sometimes they do it and sometimes not. But in her, I don't think it was done, Mariam. I think they were confident about the diagnosis. It was just diffuse large.
No, it's not about the diagnosis. I mean, we do know that it's diffuse large B cell, but I think so a lot of these breast diffuse large B cells, if that's in case if it's a primary breast diffuse large B cell lymphoma, which it sounds like that's the case because then she presented with CNS disease. A lot of them are actually non-germinal center diffuse large B cell. And those are the patients that may, benefit from, say, upfront polatuzumab, or, in the relapse setting where you are right now, these are the patients that might, have some benefit from, BTK inhibitors or lenalidomide. So another question for you is the CSF positive for lymphoma or no? Now.
During the CNS presentation, when we find a space occupying lesion, we didn't do CSF analysis.
Oh, I see. So yeah, because I see. So you could think about CNS, relapse as kind of like two broad categories. You have these patients who present with parenchymal disease, where you have like a mass in the brain, which sounds like this is what's going on here. And sometimes they have leptomeningeal disease, where you're either going to see it on the spine MRI. Or you do the lumbar puncture and you could see, CSF that's positive. Now, why is that important? So if it's leptomeningeal disease, sure, the high dose systemic therapy with high dose methotrexate will be effective in both leptomeningeal disease as well as parenchymal disease. But say we're talking now about she's had a lot of side effects, her prognosis is poor, we may consider localized radiation. But if she also has leptomeningeal disease, you're going to need to add intrathecal therapy as well, not just the radiation. But let me just talk about primary breast diffuse large B-cell lymphoma. It's not super common. It's one of the aggressive ones. It is by itself a category for CNS prophylaxis because there's high risk of CNS disease. What else is high risk for CNS disease? So you have testicular diffuse large B-cell lymphoma, adrenal involvement, kidney involvement. There's if you look on the NCCN guidelines, there's like the CNS IPI score that you could also consider. But having a breast diffuse large B-cell lymphoma or testicular or adrenal involvement or kidney involvement, regardless of the CNS IPI score, you can consider CNS prophylaxis with intrathecal. Now, CNS prophylaxis in general is also controversial because most of the data is not prospective, and you're going to see a lot of differences in practice between different centers. But if for this specific patient, what I personally would do at this time is if it's a non-germinal center, I probably would do polatuzumab with R-CHOP. I don't know if polatuzumab is available or not. But regardless, I would do CNS prophylaxis. Now, at the time of relapse, it's 6 months, post relapse. Typically, autologous transplants do not cure those patients. I mean, if you look at the older, PARMA trials and the CORAL studies, these patients relapsing within 6 months, their cure rate with an autologous transplant was typically less than 15%. And that's why, these are the patients that, we probably want to think about other things. So CAR T-cell therapy, would be something that you would do in the second line, even with, CNS disease. But I know that this is not available, and that's why I agree with Dr. Bassem. I don't know if bispecifics are available. If they are, you can consider a bispecific. You can probably add it with, GemOx as well, if that's available, or even lenalidomide. That could also be an option. But I don't know if bispecifics are available or not. But regardless, if you have early relapse post diffuse large B-cell lymphoma, the standard would be, again, CAR T if that's available. If it's not available, then you could think about a bispecific plus something else like GemOx or polatuzumab or even lenalidomide. Now, this particular patient, so she's had an autologous transplant. Beam conditioning is probably also one of the things that's not going to be super effective for CNS disease. If you have someone who's relapsing with CNS disease, you can consider, consolidation with a thiotepa containing regimen, like a, thiotepa VCNU, for example, which would have more coverage for the CNS. Because again, our problem is CNS disease with diffuse large B-cell lymphoma is one of the, most difficult, cases to treat. Anywhere. A lot of these patients, unfortunately, do not make it, even with CAR T-cell therapy. Cure rates are still low, 30-40%. So for this specific patient now, I personally agree with Dr. Bassem. I would not, talk about, high-dose methotrexate and whatnot. I think the question is, what's the goal? What are we trying to achieve here? She's not going to be cured with, with the chemotherapy alone. She's already had a lot of toxicity from it. I would personally, what I would do is I would consider, the whole brain radiation probably would be too much. Maybe consider localized. Again, we're not trying to cure her, so I would consider, localized radiation. If there's no midline shift and whatnot, I would check the CSF or maybe do an MRI of the spine. And if she's, CNS positive, she has like positive cells or leptomeningeal disease, I would add, intrathecal, cytarabine or methotrexate. And then the big question is bispecifics available or not? If they are, yes, I probably would put her on a bispecific, maybe combine it with something else, depending on what's available, like GemOx or polatuzumab or lenalidomide. But if bispecifics are not available, I would do, again, the radiation therapy if you can ask the pathologist to go back and see what the germinal, if this is a germinal center or a non-germinal center, a lot of those are non-germinal center, and those I would, she might respond well to like a BTK inhibitor, plus minus lenalidomide and rituximab. But again, is it going to cure it? Probably not. You could think about it as palliative. Some of these might sometimes be double hit. And if that's the situation, this will be very difficult to treat, and probably maybe radiation, and you can consider a bispecific, but the prognosis is going to be even worse than what we're already dealing with.
Okay, thank you, Dr. Saina. So if you do CAR T for CNS lymphoma, do you expect her to have higher incidence of ICANS, or the same incidence as any relapsed lymphoma?
Yeah, so we always kind of debate about that. It's somewhat controversial. Obviously the better the disease going in, the better it is. But we still, even if there's higher risk for ICANS, we would still consider CAR T. But let me ask you, Manar. So I know CAR T is not available in Egypt, but is bispecifics available, like epcoritamab, mosunetuzumab, glofitamab? Any of these things available?
Okay, it depends on the center. So if you're like in Maadi, you can get bolatuzumab.
Okay.
And
Well,
maybe
I'm not asking about polatuzumab. Polatuzumab is it's antibody drug conjugate. I'm asking about the bispecific.
There are bites for myeloma you can get in Maadi, but in most of the centers, no, we don't have bites yet.
I see. Yeah, then your best case scenario here is to radiate that area, not whole brain radiation, just radiate the mass. Again, palliative, and maybe consider intrathecal therapy, and then put her on zanubrutinib plus rituximab, and that's going to be the best you could do. And it's going to be completely palliative here.
Yeah, okay, thank you.
So last time we met, we discussed the issue of trying to potentially get companies interested in running clinical trials through your centers such that you'd get access to BiTEs and CARs. I wonder if that's been discussed at all. Had you reached out to any companies about their interest in trying to bring those kind of protocols to Egypt?
Well, I think Mustafa had a meeting with one of our head department, but I don't know what happened yet.
So I don't remember. It was a professor from Mansoura, right? He met with my friend, who is like in I forgot, clinical research farm companies that work with like pharmaceutical companies. But what he wanted to consider Mansoura as a center for the trials. So he didn't ask for specific trials or anything. So we're still lacking we need someone who go to ask the like pharmaceutical companies, we need this trial here. Then like the pharmaceutical companies will reach out to the clinical research company to start the trial. So it needs an initiative from like faculty member from the cancer center.
But
Yeah, Mustafa,
we're not there
actually,
yet.
actually, Mustafa, I tried to reach out to the responsible for this trial, but I could not reach to him.
Yeah, guys,
That's all.
there's a lot of things that go into play when trying to open a clinical trial. You need to have the infrastructure, the data people, the coordinators, an IRB. I don't know if there's legislation in Egypt that regulates
Yeah,
clinical trials.
there is new legislation, I think in 2022, and now there is ongoing RCTs in Egypt. The thing is, like, the company doesn't do it if it is not financially or no one asked for it. So there is a lot to conduct RCTs in Egypt, and the clinical research like company, they do all the IRB and all like the data processing for the pharmaceutical companies.
Well, these are the CROs. Yeah, so
CROs, yes.
Yeah, so but still, you need to have who's going to be collecting the data. Do we have coordinators? Do we have data managers? Do we have, there's a lot of things that go into play.
I believe they do all of that, is what I understood from them.
So they're going to have people seeing the patients in the clinic and collect the data and all that stuff?
Yeah, like clinical research coordinator, yes.
Okay.
Just to remind everybody, there was an ASCO initiative that was specifically sponsored by ASCO to bring greater clinical trials to Egypt. I'm putting the link for that again. That seemed very promising. This was started in June. Are any of you aware of this, or has it made any difference for any of you?
Yes, we are aware, but I think it hasn't started to work yet, as far as I know. I think they are going for it, but not started yet.
Okay. And do you have, since you don't have access to BiTEs and CARs, you do have access to BTK inhibitors. Do you have access to nivolumab as well?
Yes.
I think there is, yeah.
There is, immune checkpoint inhibitor, nivolumab.
Gotcha.
BTK
There
is
is phase
present.
2 data that I will forward in another link about the, ibrutinib and nivolumab. Those zanubrutinib would probably be very similar and probably less risky for the bleeding issues in any event. So that is another potential option for this patient.
Nivolumab.
Then you
So
have,
can you
I think, you could, the consensus is there is no point in doing any more chemotherapy, traditional chemotherapy. You're probably going to need Rituxan. There is good data that you can give that at a higher dose, like 1,000 milligram per meter square. You get better CNS penetration, along with ibrutinib or another BTK inhibitor. Then you could either try what Dr. Emmons proposed with an ibrutinib and nivolumab. I have had good luck with that regimen before. You could also try ibrutinib, lenalidomide, and Rituxan. I sent you another article. Now, if the lady is still in a good performance status and you do either one of those two regimens, just try not to be too pessimistic. And if allogeneic transplant is the only thing available to you, you have no access to CAR T or bispecific, something like glofitamab, and you can get the patient to a good controlled disease. You have minimal residual disease on MRI, you have cleared the CSF. It's not crazy to do a reduced intensity allo. I sent you an article about using a thiotepa-based regimen that would be recommended because you can get better CNS penetration. There's multiple leaps of faith there. You have to get her into a regimen. She had to tolerate the regimen. You have to get her into remission. But given that all of those things would have moved through, it's not completely crazy to do an allo just with a reduced intensity conditioning.
Would you still suggest that if we knew that she was double hit?
You would, because she's young. So, it's the idea is this is one shot. You're working in a resource constrained setting. It's reasonable. What I wouldn't do is use any cytotoxic agents anymore because it's proven to be chemorefractory, whether it's double hit biology or functionally double hit biology. I think at this stage of the game, figuring out if it's double hit or not might not change what we recommend. Knowing if it is non-GCB phenotype would be helpful in being more confident about recommending an IMiD and a Bruton tyrosine kinase inhibitor. Probably you need ibrutinib a BTK no matter what, one with a good CNS penetration. So if you choose ibrutinib is good, zanubrutinib is good, acalabrutinib is not good because it doesn't penetrate the CNS as well. So either you have choice between ibrutinib and zanubrutinib. You could combine it with nivolumab. That's perfectly fine. I have good results with that. You could combine it with lenalidomide and Rituxan. That's good too. You can pick either one of two, whichever is available to you. And do give that regimen for a good 2 months. Okay. And then repeat an MRI, repeat the LP. And if she enters remission and you have a sibling donor that's available, you could do a reduced intensity allo with a Cytotepa-based regimen. That's probably the only shot you have at durable remission, unless you can get access to something like glofitamab.
Okay. So anyone want to add anything before we jump to the next case? We have time.
I don't know. The next case might take us a bit while, but I would say I concur that radiation, localized radiation, is maybe your best first step in getting BTK inhibitors. I hope that if zanubrutinib is available, I know ibrutinib is, along with Rituxan and lenalidomide, is a reasonable move to try to get the patient in remission. Allotransplant. I think I might be a little bit more pessimistic than Dr. William here, and I said like the outcomes are very tough in these patients. Most of their missions are short-lived, and the allo effect, I'm not sure if it is going to do a whole lot in this patient.
To continue our case, we have again panel decision after CT scan, which showed regressive course in the space occupying lesion. And we have decided the patient to receive the HAP protocol, and she already received the 3 cycles of the HAP protocol with the latest MRI on November 2025 showing regressive course regarding this frontal lobe subcortical space occupying lesion, but unfortunately new developed faintly enhancing patches within different sites of the brain in thalamus, subthalamic regions, subcortical regions in the frontal lobe. So would you recommend radiotherapy now, and if this is considered a response?
Yes, they suggested previously to receive radiotherapy. Okay.
Yeah, this is
So
progressive disease. Should do radiation, but it sounds like it's more diffuse now, so probably hope right now.
mhm.
I mean, you are in the palliation realm at this point. I mean, if you don't have access to an immunotherapy intervention of a sort, you're pretty much in the out of the curative realm at this point. You're pretty much anything that you do would be palliative in nature. It's not going to result in any durable remission. So in any event, I don't recommend you give any more chemo, any more cytotoxic chemo. You can use targeted agent, you can do radiation, but I wouldn't give any different combination of chemo at this point.
Okay.
I have a question. So is CAR-T producing a durable response in these patients? Because there was a meta-analysis done 3 years ago that reported that only 50% were disease-free at 6 months.
And
Of course.
that's fantastic for this
Yeah.
situation. I mean,
That's
it's
better than expected, yeah.
right. So the question is, whenever you say something is effective or not, you have to look at what your denominator is. So what are you comparing it against? So if you have 50% of the patient who have durable remission, that's a huge success. There is nothing else in this situation that will give the patient any kind of durable response. So it really depends what you're comparing it to. There is no question you have a higher risk of toxicity when you do CAR-T for CNS disease, but what is the alternative? You know, anything about risk is depend on the context. What's the other thing? If you're comparing a toxicity of a certain thing compared to death, then you know it's less toxic. You know, so
And
yeah.
what do you give after progression on CAR-T?
You can try bispecific. But I mean, generally, if you have secondary CNS disease and you get progression on CAR-T, you're pretty much are sort of at an end of life situation. But you can certainly try bispecifics after CAR-T. There is some interesting data that, and this have been true in my own personal experience. If you have progression after CAR-T, in general, not specific to CNS, but in general, if you have progression after CAR-T, there are two main reasons for progression after CAR-T. One of them is that you lose a target, which is usually CD19 for the commercial CAR-T, or you have T-cell exhaustion because you make the CAR-T out of the patient's own T-cell. So if you can use medication like lenalidomide in small dose, there is proven data that this can reverse T-cell exhaustion. So you could restore or rekindle the CAR-T response. So when you give lenalidomide for relapse post-CAR-T, I've seen that personally happening in a handful of patients, and there is few published smaller report that you could have you can have durable remissions after CAR-T progression if you use a drug like lenalidomide. The other thought is some of the relapses after CAR-T tend to be localized. So there's some data that if you irradiate those lesions, again, we're not talking about CNS disease, we're talking in general. You can irradiate those and keep the patient in remission for longer. So not all relapses after CAR-T are equally terrible. Some of them are worse than other, and that's still something that's being investigated. One of the things that you should never do after CAR-T is to give cytotoxic chemotherapy, because what you will establish is you're dealing with a chemorefractory disease, mean if you give chemotherapy, it's not going to kill the lymphoma. What it will do, it will kill the CAR-T. And then you can transform, and I've seen that happening before. You can transform an indolent type of relapse into an explosive type of relapse. So CAR-T might be still having some therapeutic effect, but the lymphoma is breaking through. It's sort of like a tug of war. You have two sides pulling on the rope, but the CAR-T still have some effect. The disease is not fully explosive. But then you give cytotoxic chemotherapy and you don't kill the lymphoma, you kill the CAR-T. And you can transform a slow indolent relapse into an explosive relapse. So one thing you should never do after CAR-T is to give chemotherapy, particularly if you use an agent that kills lymphocytes, something like bendamustine or something like that. That would be one thing that you should never do after CAR-T.
So we can't use the CAR-T as a bridge for a transplant?
You can, depending on the disease. So typically with ALL, the relapse rate is high, and ALL is a disease of a younger people. So there is a little bit of a controversy, mostly in the pediatric world, that if Kymriah, for instance, that's enough for curing ALL, pediatric ALL, or you need to follow it with an allogeneic transplant. In our adult diseases, usually not, because usually our patients are older, they're pretty beaten up. Once you get them through CAR-T, you're pretty much done. You're hoping for remission, and then you're done. Now, if it relapses after CAR-T, especially if usually I don't know. I haven't seen that happening a whole lot. Right now, especially with B-cell lymphoma, we have a lot of different choices that you try to cycle all of those different things and kind of try to keep the patient alive one way or the other, but you don't use it just as a bridge. Usually a CAR-T in aggressive B-cell lymphoma is your final step, usually. And then if they relapse, you try a bispecific if you haven't tried a bispecific before.
One other thing to say about the CD30 question, this would be a rare circumstance, but there is brentuximab, which has some good activity peripherally and even to some degree CNS. So if this patient was CD30 positive, that might be another avenue, though that would be very rare. More likely, again, something like a BTK and one of the other drugs that has been mentioned will be the way to go.
And I wanted to just, as a kind of a shout out for the FDA approved Axi-cel like a couple months ago for primary CNS lymphoma based off an investigator-initiated study. So I know investigator-initiated is always surrounded by difficulty and sometimes are not taken, but the FDA took an investigator-initiated study on only less than 20 patients and expanded the label for Kite's product in primary CNS lymphoma, as well as it included patients with secondary CNS involvement to receive CD19 CAR T-cell therapy. So I think there's definitely a good role here. And the alternative, I know 50% might not be great, but the alternative is death. So I think 50% against death is really a good outcome.
Okay, thank you. You have answered all the questions of discussion.
Okay, will we have time for the next case, or will we wrap up?
Can we keep the next case for our next meeting, so we stick with our 1 hour and not go beyond, and maybe we can do it right after Ramadan, and inshallah, and we can shoot for May, I think, or I mean April, to find the time for us to gather again.
Yes, sure.
Okay.
Any other questions? Well, thank you very much, Mariam and Manar, for putting this together, and I truly appreciate the panel. Thank you very much, Dr. William, for joining us. We look forward to having you with us. This has been very productive. Dr. Mabed, Dr. Sameh, and Dr. Emmons, as always. Thank you very much, and have a good one.
Thank you.
Okay.
Thanks, everybody.
Thank you all.
Thank you.
Bye.
Bye.